Well, hello and welcome to the Kids Brain Tumor Cure Foundation webinar. We're very excited to bring you today's discussion focused on important new outcomes research and its implications to the care of children with low-grade brain tumors. This will be presented, and I'm thrilled to say, by Dr. Mark Kieran from the Dana Farber Cancer Institute, who joins me here in Boston. Welcome, Mark.
Thank you, and welcome, everyone.
Well, my name is John Regnoni, and I have the pleasure of being today's moderator. I'm here on behalf of the Kids Brain Tumor Cure Foundation, where I serve as a board member. But more importantly, I'm here as a parent of a child successfully living with a low-grade brain tumor. And on this call, I hope to be the voice of the parent in the room. So we've received a tremendous response to this webinar with parents and researchers from across the U.S. and the world calling in. So this is going to be a great session. We welcome our parents attending and hope you find it informative. We also welcome our research partners and other Children's Brain Tumor Foundation partners who are listening in, and we thank them for their support and friendship. So first, I just want to confirm that everyone can see the whole screen, so a little bit of logistics so you'll have a good experience during the hour. On the title page, you should see the header, which includes the Kids Brain Tumor Cure logo on the top left, and then Funding Research Finding Cures on the top right. And then with high technology here, a smiley face on the lower left and right margins. So if you're not seeing this, then go to the drop-down arrow for Zoom at the top left of your screen and click on Scale to Fit as the option. And that would allow you to see the full screen. And you're going to have to just take a look at that and adjust if you need to. But if you saw those items, then you know that you have the full screen. So in terms of timing, Dr. Kieran will be presenting for approximately 30 minutes, and we will also have 10 minutes for Q&A at the end of the webinar. So please, please feel free to use the questions section of your control panel to ask your questions. Now, we may not be able to get to all the questions, as you could appreciate, given the limited time, so we will follow up with individuals after the webinar with any additional information needed. So quickly to recap, for some in the audience here, you already know about a Kids Brain Tumor Cure, also known as the Pediatric Low-Grade Astrocytoma Foundation. We were founded in 2007, and we're really a parent-driven organization with strong support from a wonderful scientific advisory board. And we got started really as parents when we realized that despite many pediatric cancer and brain tumor organizations, there was really, shockingly in a way, little research being done to help children with low-grade brain tumors, despite it being the most common form of children's brain tumors, and that standard chemotherapy treatments were more than 20 years old. So really to change this, we enlisted kind of the best minds really internationally, and we focused on three things. We wanted to accelerate the pace of the treatment, really moving from bench to bedside with treatments to help our children, to really bring partnerships together and galvanize the experts in a coordinated way, and then to support the children and the families. And while no family bargained for this disease, we wanted to really provide a community to make sure that families knew they weren't alone. And in addition to our website and webinars like this, we have a Facebook group, we have a Facebook page, and a low-grade glioma Yahoo listserv, really for that purpose, for families to ask questions and support each other in a safe environment. So, with that said, the webinar today, I'll be brief because Dr. Kieran will get into it in more depth. But our goal is simple today, to really empower you as parents and to demystify a very complex topic so you know what simple actions you can take to support your child. So, now let's get to the main event. I'm joined here in Boston with Dr. Mark Kieran, who along with Dr. Chuck Stiles, is the co-director of the Pediatric Low-Grade Astrocytoma Program. Mark, you can see on the titles here, has quite an impressive resume, but I can tell you firsthand that Dr. Kieran is a remarkable researcher, and his commitment to advancing low-grade research is truly inspiring. Dr. Kieran, welcome, and thanks for being with us today.
Well, thank you very much. Okay, so what we're going to do is I'm going to take you through some of the concepts related to long-term survivorship in low-grade gliomas, and we're going to focus on the survivorship because the survivorship issues are actually one of the critical components in deciding how we're going to move forward with therapy. So just before we begin, as you can see, a large part of my role here at the Dana Farber and Boston Children's Hospital is the development of new drugs that target specific mutations for the therapy of a variety of brain tumors. And I therefore run a number of clinical trials involving a number of different companies. I don't have any stocks or patent rights or employments or anything with any of those, but just so you're aware that because some of the things we're going to talk about, particularly in the next webinar, relate to some of the discoveries of both the targets and the molecules, I wanted you to be aware of that involvement. So what we're going to do now is focus again, as I said, on explaining the understanding of the long-term outcome of pediatric low-grade gliomas and how this influences therapy. And that's obviously critical for you as parents because it has impact on the appropriate choice of surgery, radiation therapy, chemotherapy, and targeted agents, and understanding those issues can therefore help you, both at the time of the original diagnosis of your child's tumor and at times when the tumor starts to grow again. And the concept that if you're informed and if you understand those issues, you can make better decisions. Now, remember that everything that we're going to talk about really comes out of our involvement with the Pediatric Low-Grade Astrocytoma Foundation and a Kids Brain Tumor Cure, and that obviously the research that we have done and are doing will come out of that, so that this is not a static issue, that as things move forward, some of the issues we talk about today may change, the priorities may change, and it's important to therefore understand that it will always be important to continue to update where we are. And obviously our hope is that the research provided by the Kids Brain Tumor Cure will allow us eventually to have a simple and completely effective non-toxic therapy, which to some extent is what we really want. So I'll turn it back over to John.
Yeah, that's great, Dr. Kieran. So Mark, before getting into the research, which I think is extremely exciting and really provides a window into how we can better care for our children, can you spend some time grounding everyone in the disease? So as a parent, I know it can be very daunting on many levels, even though I've been at it a while. And really, I think parents want to understand their child's situation. It seems like it starts with first understanding the disease.
Okay, so so we can certainly do that, although this maybe isn't going to make it, hopefully it will make it more clear, but certainly not less complicated. So what you should see in front of you right now is a slide of the distribution of the brain tumors that we see in kids. And you can gather that there are a lot of different types, the largest group of which is actually the low-grade astrocytomas or low-grade gliomas, terms that we often use interchangeably. And this, in fact, has accounted for part of the confusion in the field. The idea that low-grade astrocytomas are a single slice of the pie, as if they're a single entity, has often generated a lot of confusion. In fact, in this next slide, you'll see that we have a number of ways in which we talk about types of astrocytomas. So at the top are the way we categorize astrocytomas or gliomas by what's called the World Health Organization grade, which was a kind of structural assessment decided on some 50+ years ago of the way to grade a tumor on the assumption that high-grade tumors would be bad and low-grade tumors would be much better. And for the most part, that's relatively true. And you can see that there are pilocytic astrocytomas, or what are called grade 1 astrocytomas. There are fibrillary astrocytomas, or grade 2. There are pilomyxoid astrocytomas, also grade 2, or sometimes we just lump them together into low-grade glioma as grade 1 or grade 2. I suspect each of you as a parent is probably looking at this list to find where your child's tumor falls on it, because that's the only tumor of the list you're really interested in. Whereas, as you can see, these are all defined as low-grade gliomas. In fact, sometimes we don't even biopsy them. We just know what they are based on their location. So an optic pathway glioma, a posterior fossa pilocytic astrocytoma, or tectoglioma. And sometimes we base the title of the tumor not based on its WHO grade or location, but by one of the cell types identified in the mix of the low-grade glioma, such as ganglioglioma, oligodendroglioma, and so forth. And obviously, what further adds to the confusion for many parents is that a pilocytic astrocytoma, which can also be called a grade 1 astrocytoma, if it's in the tectal region, could also just go by the name tectoglioma. So you can see how the same words are used interchangeably back and forth that generate a lot of confusion. Now again, as you're sitting here focusing on exactly which one of these your child has, it in fact turns out that that's not as important as you had originally thought. Remember that the way we diagnose these tumors is based on their appearance under the microscope. And the microscope is 500-year-old technology. And it's maybe a little concerning to think that we're making major decisions on how to treat your child's tumor based on that therapy. It would be like using leeches for blood therapy in today's environment, something no family would tolerate. And yet here we are comfortable doing something that at least my parents told me we should never do, and that's judge a book by its cover. But a microscope is basically a way of looking at the way the cell appears under the microscope and then deciding that based on its appearance, without knowing what's actually on the inside of the cell, knowing how it will behave, whether it will respond, when it will stop, all of those different issues. And you can understand how that's turned out to be less than accurate. In fact, in this next slide, what it really shows you is more what is the appropriate understanding for low-grade gliomas. And you can see that we still have the tumors listed across the top, but you'll notice that instead of being in the box of low-grade glioma, exactly where a grade 1 low-grade glioma starts and a DNT or a low-grade glioma NOS start is no longer quite so clear. And in fact, we see cases where a child diagnosed with a grade 1 pilocytic astrocytoma recurs now as a DNT or as a ganglioglioma. There is so much back and forth here that we're beginning to see low-grade gliomas, at least based on their microscopic appearance, as a much more fluid change. And that's important for you as parents because it means that if your child was diagnosed with a fibrillary astrocytoma or a grade 2 astrocytoma, you don't need to just know about grade 2s because that tumor could come back as a grade 1 astrocytoma the next time it recurs, and we therefore have to think of them more in that context. So the next slide shows you two kids that have exactly the same tumor, at least based on that outward microscopic appearance. And if you look at the bottom part of this slide, where you should see the microscope images, for example, you can see all of this pinkish stuff, which is called the fibrillary background of a classic low-grade glioma or pilocytic astrocytoma or grade 1 astrocytoma. They all mean the same. And then you can see this other part where these little white areas are. Those are called the microcystic changes. And if you have these two things at the same time, in addition to this little pink fiber called a Rosenthal fiber, that makes the classic diagnosis of a pilocytic or grade 1 astrocytoma. But what's important to recognize is that the kids have exactly the same tumor here as over here, and yet the behavior of those two tumors is going to be significantly different. Children with the tumor of the image that you see on your left, in fact, often a surgeon can go in and completely cut that out, whereas the tumor on your right is in a part of the brain where if a surgeon ever tried to do that, they would cause significant damage to the vision, to the hormone centers, and to much of the functioning of the brain. So here's a case where the microscope tells you that these two kids have the same thing, and yet the way they're going to be approached is completely different. That means that the diagnosis, the microscopic diagnosis, doesn't tell the whole story. So this is an example of an MRI of the newest kind of imaging for kids with all kinds of brain tumors, including low-grade gliomas. And in fact, we now have imaging that very effectively will help us tell when somebody's tumor is likely to be a high-grade glioma from those that are a low-grade glioma. And that's critical because the way they're treated is completely different. Unfortunately, the imaging technology that we have right now, we are just starting to get to the point where we may actually be able to tell what type of low-grade glioma you have and what mutations are causing it. And that, of course, would have an impact on the way we treat it. So we could have a 1-hour webinar just on some of the new methods of imaging that we're not going to focus on today, but I wanted to let you know how exciting and important some of these changes are.
That's great, Mark. So that was really good grounding about low-grade gliomas, low-grade astrocytomas. As you said, that name really gets tossed around, and it's very similar in nature. And what I'm taking from it as a parent is there's different ways to categorize tumors. The field's rapidly evolving, and a parent should be working with their doctor to understand the tumor type and what that means as far as impact. Is that right?
Absolutely.
Excellent. So Mark, let's segue to the treatment. So can you really give us a sense of the different types of treatment available and how to think about it?
Absolutely. So let's, the approach for pediatric brain tumors is not significantly different from the approach we use for any other tumor in the context, and this would be as true for ovarian cancer as it is for a child's brain tumor. There are three major modalities. There's surgery, radiation, and chemotherapy, and obviously each of them can have a role. Sometimes we favor one over another. Sometimes we need all three of them. Again, the advances in each of these areas, both radiation and neurosurgery, have been absolutely outstanding. And what you see in front of you are just some of the new techniques that have really started to revolutionize the operative opportunities. Remember that a surgeon can take out anything they want, right? So if there's a spot there, they can go after it and cut it all out. The issue is that for low-grade gliomas, that's not always the right answer. And forcing a surgeon to take out something that shouldn't be taken out because it would do so much damage to do so is where the experience and knowledge of the surgeon comes in. Now, perhaps the biggest advance that's at least relevant for kids with low-grade gliomas has been in the concept of what's called MR operating suite technology, which in fact is particularly close to our heart here because this, in fact, what you see in front of you is the first machine ever developed. And for those of you that can see it, you can actually, in fact, even see the surgeon's fingers in the brain while they're operating. And that's critical because it means, by definition, this surgeon knows where he is every second of the operation. They know if they're leaving something behind, if there's any residual tumor. They also can tell where all the critical structures are so they avoid them. Remember, the key isn't always for the surgeon to take everything out. It's for the surgeon to take out everything that is safe to take out. We'll deal with the rest by other technology. So this is pretty exciting. In fact, this technology has now advanced, and the one you see in front of you is a child that was in the operating room. In fact, this part here is the open part of the skull so that the surgeon can come in. And what you can see in this image here is that this yellow stuff coming right through the tumor, which is this green stuff, are actually the fibers that connect the upper part of the brain to the lower part. So if a surgeon goes in and lumps out the tumor, they will cut all of these fibers, and basically you won't be able to move half your body. So this is a circumstance where we know you're not going to, it's not that you can't take it all out, it's that you shouldn't try to take it all out. Now this patient was actually awake, and the reason this patient, this older adolescent, was awake is so that they could answer questions to the surgeon, so that, see this little aqua area here, this is part of the thinking part of the brain, which means the surgeon should not attack it by coming in this direction. They need to come at it from this direction to avoid those. Take a small biopsy here to be sure that we can find out what it is without doing any damage, because that's going to be critical in the long term for reasons we're going to talk about momentarily. Now, if you said, of all of the things that are important in terms of, for the surgeon, what is it? Obviously, how old is the patient, an infant, a child, an adolescent, the location of the tumor, the aggressivity of the tumor, is it malignant, is it benign, all of those things. But it turns out if you said what is the most important thing in terms of how your child will do coming out of the operating room, actually the number one determinant is none of those things. It's actually the number of years of experience that neurosurgeon has had doing this operation in kids. So for those of you, for example, that live in Boston, where at Children's Hospital here we have 8 pediatric neurosurgeons who do nothing but this, that's fine. But if you live, for example, in a state where there might not even be a single pediatric neurosurgeon, and that if your child goes to the hospital, there's an adult person who remembers having read about one of these procedures once during their adult training, unfortunately, that's not the person that should be doing the procedure. Because remember, the number one determinant of how your child is going to do is the number of years of experience that surgeon has doing that procedure in kids. So can't underscore that enough. Now, similarly for radiation therapy, the radiation therapy has also had an incredible number of advances. Proton therapy, photon therapy, there are all kinds of things. And again, we could have a multi-hour conversation on all of those advances. But what's relevant for us is not that radiation doesn't work. All of those techniques are, in fact, incredibly effective at treating pediatric low-grade astrocytomas. In fact, after surgery, they are the most effective therapy. The problem is that they have a lot of toxicity. And the toxicity comes into 5 major points, the 3 top ones of which are the most critical. That radiation, unfortunately, damages the developing brain, which in children is a must, and that unfortunately, that's a damage that stays with you the rest of your life. Unfortunately, radiation isn't just a very effective way of treating a tumor, it's also a very effective way of causing tumors. And the tumors that they cause are not these low-grade benign lesions, they are these highly malignant, aggressive tumors, the majority of which cannot be treated or cured effectively. And one thing we don't want to do is take a low-grade tumor and turn it into an incurable high-grade tumor. Because you're radiating the tumor and the blood vessels that feed it, you're also radiating the blood vessels of the brain, and that often results in strokes. Now, for those of you that have had a grandparent that's had a stroke in their 70s and 80s, you know how devastating it can be. Imagine causing a radiation-induced stroke in these children once they turn 15 or 20, something that they have to carry with them the rest of their lives. And then if you have to irradiate the spine, because that's where the low grade is, you can cause some growth delay. If you radiate the part of the brain that produces the hormone, you may need to be on hormone replacement. But you can envision that those top 3 are absolutely critical because like me, I have children as well. To know that you want your children not just to survive their tumor, but to be able to graduate school and go to college and get a job and have a relationship and have kids, the things that we all want for our kids, unfortunately, radiation can do a lot of damage to so that those things don't happen. And therefore, it's not just a question of what's the most effective therapy, it's what's the most effective therapy to ensure that my child has the long-term outcome that I would want for my child. Now, the major damage done to the cognition system of children is based on the fact of age. Are they children or adults? Because radiation does less damage to adults. It still damages some of the cognitive function of adult, but not as much. The location of the tumor and the dose of the radiation. But unfortunately, when your child gets diagnosed, we can't change their age, we can't change the location of the tumor, and we can't change the dose of radiation. You need the dose that's effective for these tumors. So unfortunately, if you have radiation, you've got to do it under those circumstances, and you would have to accept the toxicity.
Okay, Mark, so let's recap. So that was extremely helpful. And in fact, I think on the radiation therapy issue, we're getting some questions from the audience that we'll come back to during Q&A because I think there's a lot of interest there. But we've done a basic view on low-grade brain tumors and what an astrocytoma and glioma are. We've talked about treatment options focusing on surgery and radiation. Now I know we want to introduce this exciting research because it really ties together potentially the outcome of these children. So can we now segue into the research, and can you give us a sense of what that research is, and then what does it mean to a parent with a child with a brain tumor?
Absolutely. So let's, obviously we can't talk about all of the research. There's an enormous amount of work going on in terms of understanding the underlying biology and mutations that cause these tumors. But one of the things we started focusing on some 15 years ago was understanding exactly what happens in sense of the long-term outcome for kids with low-grade gliomas. And what I wanted to present to you now is some of the more recent work that we and others have been doing to really understand this process. So in front of you is this thing called the SEER, or Surveillance Epidemiology and End Result Database, which basically tracks how kids are doing over the long term. And what we did was we analyzed 4,400 kids with low-grade gliomas under the age of 18 with respect to their race, the location of their tumor, the histology of the tumor, grade 1, grade 2, pilocytic, et cetera, whether they got radiation therapy or not, when they were diagnosed, to look to see whether some of the new therapies like proton radiation therapy, whether the new neurosurgical techniques have had an impact, the gender of the child, the extent of the surgery, was it just a biopsy, was it a complete removal, the grade of the tumor, as I talked about previously, based on its appearance under the microscope, to ask, how do all of those factors affect what will happen to my child? So you're not really meant to read this, other than this is some of the data of those 4,040 kids, looking at their different sex, their ages, the average age of which was 9, but going all the way from early infancy up to the age of 18. Here's the histology, the grades, the locations of the tumor, how much of it got resected, whether or not they got radiation. So you can see all of these variables were studied in this population. And this is perhaps the most important slide we're going to talk about. It looks at what happened to those kids. And basically, if you're a child diagnosed with a low-grade glioma, and notice that in these months from diagnosis, where we're talking about 30, 40, and going up towards 50 decades of life. So obviously, you can see that the vast majority of kids with a low-grade glioma will be a long-term survivor of a low-grade glioma, in spite of all of those things that I said that we did to them. Notice that by contrast, adults, their low-grade gliomas are completely different. Once an adult gets a low-grade glioma, unless the surgeon can remove it all initially, that low-grade glioma is slowly going to become more and more malignant and eventually result in death. So the vast majority of adults die of their low-grade glioma. The vast majority of kids never die. They live a normal lifespan. And that's important as we think about the treatment option. And although we're not going to talk about it in this webinar, we'll have another webinar on the molecular changes that occur. And we now understand the molecular mutations of adult low-grade gliomas versus pediatrics and why they have a different outcome. Now, if instead of looking at all of the low-grade gliomas combined, you just, for example, look at the pilocytic astrocytomas and the diffuse astrocytomas, the same thing holds. The kids are going to be survivors, the adults are not. And I could have shown this for each of the individual diseases. Again, I don't want to waste too much time on it, in the sense that you see the same thing for all of the different subgroups. So this is broken out by the different histologies. And again, you can see that overall the histologies, again, continue to do very well. Children with a low-grade glioma, almost all of them will be a long-term survivor. You'll notice that if you have this diffuse astrocytoma and NOS category, particularly related to a subtype called a pylomyxoid astrocytoma, you can see actually that there's a little bit of a rapid drop-off. And that's because these kids present, this one subgroup presents with a very problematic, severe diagnosis at the very beginning. And if you can get them to survive that, then again, you'll see that their long-term outcome is excellent. So if we can stabilize a patient stably, the odds that they will survive long-term is outstanding. In fact, this next slide, which shows you what happens when we treat some of these patients. If you take a child with a low-grade glioma in which the surgeon cannot remove it all, because doing so would do too much damage, and you treat it with things like chemotherapy, but don't give it radiation therapy, your survival is much, much better than if the surgeon cuts it all out, but then they go ahead and they give you radiation, because in fact the radiation does so much damage. Remember, it causes strokes, which can be fatal, and it causes highly malignant tumors that can be fatal. You're going to do worse if it's taken all out and you need radiation than if you don't take it all out and you only use things like chemotherapy. And this again reinforces the point that the issue is not to find the most effective therapy. It is to find the most effective therapy that in your long-term survival does not damage you to the point that it itself either causes your death or damages your function. And this last slide, now if you look at it, so this is a slide of patients that start at age 23. So these are the adult survivors of low-grade gliomas. And what you're basically seeing here is the months of survival after your 23rd birthday. And basically it means that as again you go 4 and 5 decades, so you're now in your 60s and 70s here, you can see that again your survival is excellent. In fact, the slight dip in the curve is because, of course, eventually as you age, you start getting things like heart attacks, the things that you would expect to start causing some increasing problems with age. And so this is kind of good news for you because it means that if we can get your child to be an adult, the tumor will stop, not grow, and your child will basically then just have to deal with all of the issues of old age like everybody else. And what more can we ask for than what every other family wants for their children, and that is a normal lifespan. So this next table shows you some of that data, and again, without going through the details of it, the first two categories are the significant increased risk of death if you get radiation compared to kids that don't get radiation, all of whom have the same disease, a low-grade glioma. And those three categories here are defined by those kids that have that one specific subtype of tumor called pilomyxoid, which typically occurs at very young kids under the age of 2, with a group that is not a pilocytic astrocytoma. It's this unique subtype, and it rarely occurs in the cerebellum. It occurs elsewhere. And if you take out this group and you don't radiate, your survival is excellent. So when we kind of put this all together, kids with low-grade glioma have incredibly low mortality related to their disease. Almost all patients will survive their tumor. Has any child ever passed away from a low grade? Of course, the answer to that is yes, but it's uncommon. And when when kids do succumb to the disease, it's as often because of what we treated them with as it is the disease itself, which is again why as a parent you have to be so sensitive to the choice of therapy, because choosing a therapy to minimize morbidity is critical in terms of the long-term outcome for your kids. Radiation is the most effective therapy for these kids, but it unfortunately is also the most toxic to long-term survivorship, and the reason why we rarely do it. We here in Boston get between 40 and 50 low-grade glioma kids a year, which means over the last 20 years, we've literally had like 1,000 kids, and we probably needed to radiate 5 or maybe 10 of them. The vast majority don't need it if you are cognizant of these issues. So putting this kind of all together, what happens when you're either diagnosed at the initiation of the discovery of your child's disease or at one of the recurrences is, as I said, you have to find a medical center that's comfortable with these patients, in particular a neurosurgeon. The other thing is that because you may not have that locally, you need to be comfortable asking for a second opinion. And there are two things that are going to happen. If you're at a place that is confident that they have done the appropriate analysis in order to give you the recommendations they gave you, because they have that expertise, they will be completely comfortable asking or having a second opinion be given because they know that the results they gave you were accurate. Places where people don't want you to get a second opinion is because they're not sure that they actually gave you the right recommendation, and they don't want to be contradicted by a site that has more expertise. But of course, that of all places is where you need the second opinion the most, which means if you ask for a second opinion and you get the opinion that confirms that they were right all along, everyone is happy. And if you get a second opinion that tells you that the original opinion was wrong, then you're glad you got the second opinion, which means you should always get a second opinion. And then remember that although I said the surgery is critical in terms of the area of expertise, once the surgery has been done, the treatment per se, with all of the different therapeutic options for the most part, can usually be done at your local institution, so they will have that expertise. You don't need to come to a place like Boston to get the standard approaches for most of these. They're things that even smaller centers have a lot of experience with.
So Mark, just to add on from the parent's perspective, and I've been on the listserv many a time when I see a parent asking about what they should do at the time of diagnosis. And first, of course, the parent understandably is overwhelmed, but we regularly try to introduce the second opinion, and I think it's human nature to be concerned about that. One tip, just to throw out from a parent's perspective, that seems to work very effectively, is to also note that this is a very common thing, and when talking to the doctor, to stress the fact that they've learned from others that it's critical to have that second opinion, so it doesn't become personal, and in fact it becomes just that you're carrying out what is the best practice. So I just would share that because I know it's difficult when you're dealing with someone who's caring for your child to question it all. And I think it's imperative, based on what you said and the Foundation's experience, to make sure that that second opinion occurs, because it can be so helpful both at the time of diagnosis and then perhaps at inflection points where there's a big decision to be made with the child.
Yeah, and as I said, a good team will not mind that you're asking for a second opinion.
Excellent.
Okay, so let's talk about just kind of to put things into context of the different treatment options. So surgery, it's important. If the surgeon can easily and safely take it all out, then that's always optimal. If the tumor's in a place where that's not possible, going for broke is never an acceptable option, because these kids will survive even if the surgeon doesn't take it all out. We have all kinds of other modalities that can be effective. The radiation therapy is the most effective therapy, but it's also the most long-term toxic. And this is where you have to separate out a little bit of what's effective from what's toxic, because it's unusual that your oncologist will recommend a less effective therapy, like chemotherapy, to a patient. Most families want to hear the most effective first, but it's because they're taking the toxicity into account, as should you. And obviously, as I said, chemotherapy, we accept that it's less effective, but because of the long-term toxicity issues, it actually is the preferred initial therapy, and in fact, it's the preferred therapy at multiple recurrences as well. Now, the table that I just put up in front of you, which was from an article that we just published, which you're not supposed to be able to read, are just a listing of some of the chemotherapy trials that have had efficacy in treating kids with low-grade glioma. So the good news for you is we have lots of really effective therapy. They're not as good as radiation therapy, but they don't have the toxicity that radiation therapy does, and therefore you can know that we have lots of opportunity to take care of your children. What I'm showing you right now is, in fact, the results of the most recent completed national trial here in the United States for kids with low-grade glioma. So this was over 500 kids, just like yours, that had a low-grade glioma. And you can see that some of them have a genetic disease associated with the disease called neurofibromatosis type 1, and they do slightly better than the kids that don't have this disease. But even so, you can see that eventually the tumors will come back. This is called the Kaplan-Meier curve. So every time the line dips a little bit, it means that somebody's tumor has started to grow a little bit. And for neurofibromatosis, that does occur. And I won't talk about that anymore right now. Instead, I'm going to focus on the kids without neurofibromatosis, but the concepts are the same. What you can gather from this, based on the fact that the line drops, is that odds are, if you need to be treated for a low-grade glioma, odds are the tumor is going to start to grow at some point in the future, based on the fact that these curves are dropping down. Not everybody will need to be retreated, but the majority will, about 60%. If you draw a line around here, it means 60% will progress, 40% will not. But what you don't see from this is that the vast majority of patients will live for the next 70 years. So although the tumors keep coming back, what they don't do is cause you to die, which means we can treat them again and again, and eventually, as I showed you before, once you get into your 20s, the tumors will stop for the rest of your life and you're done, and the only thing you have to live with is the toxicity you created getting here, which is why not letting too much toxicity happen while you're getting here becomes so important. Now, here's the point at which around half of the patients have already recurred. So if you draw a line down, by about 3.5 years, half of the kids' tumors have started to grow. Now, that doesn't mean that once your kid starts chemotherapy, you only have to worry after 3.5 years. If somebody's tumor progresses after 1 year, somebody's tumor doesn't progress for 6 years, but on average, this is where it will happen, and that's what these curves are meant to tell us, recognizing that, again, almost everybody will be a long-term survivor. So if we take that kind of knowledge base, optimal therapy isn't just what works best, it's what works best taking into account the long-term side effects of the treatment. Chemotherapy is effective, but if you start chemotherapy, you almost have to prepare in your mind that at some time in the future, your child may need another course of chemotherapy and maybe need even a number 1 or 2 or 3 more after that. And that's part of the reality of the chemotherapy treatment, knowing that it has the goal that if we can get you to your 20s, whatever made these tumors start will turn itself off and you'll never have to worry about it again. And the recognition that that happens is critical because it therefore guides what should happen both at the time of the original diagnosis and at the time of progression, knowing that those are going to happen. So as we kind of talk about, well, what's next and where do we go from here? And again, that was not meant to be the part of this webinar. It will be the discussion of a separate webinar, is through the Pediatric Low-Grade Astrocytoma Foundation and a Kids Brain Tumor Cure, we've now discovered the vast majority of the mutations that appear to give rise to these tumors, although we still have a little more to go. And clearly, we've now developed a couple of novel drugs that are being supported by the foundation to see how well they work in kids with those specific mutations, and those studies and trials are ongoing, and that clearly with better research, with continued research through a Kids Brain Tumor Cure, we have the opportunity in the not too distant future to understand what causes each child's tumor to start and to select the drug that we can give to that specific child that will stop their tumor from growing without doing any long-term damage. And that obviously is the goal of where we want to go. So as I said, we're going to plan for a second webinar that will address these issues that kind of take us forward. But what I wanted to do now was give you, the families, an opportunity to ask some questions that kind of deal with the issues we've talked about at this webinar. So what I'll do is I'll turn it over to John now, and maybe we can move forward from there.
Well, this was great, Dr. Kieran, and I think I want to remind folks, I'm sure it was a whirlwind because there was so much information being thrown out at you. And the idea was to both try to simplify it as much as possible, get the important points out, but I want to remind you that this webinar will be available for you to listen to again in a matter of 2 or 3 days. And then we will be following up in terms of specific questions directly with you and trying to help in any way in that regard as well. So thank you for the wonderful amount of questions that have been submitted. Mark, I'm going to try to hit a few that speak to the majority of the questions that we received from parents. You've touched on elements, but I think many are looking just for a little bit more context from you. One is just this point about will tumors come back? How often do they? And even the question about do all tumors become dormant? I think maybe it's just putting a finer point in terms of, as a parent, you're always wondering what's next, and your child may have successfully had a treatment, whether it's chemotherapy, surgery, radiation, and they're wondering what is the probability, or what do I have to worry about next? So can you just give a sense of how that looks as a parent would consider where they stand in that spectrum?
Yeah, so the answer is yes. No matter what modality is used initially, there's a chance it can come back, and you can probably have figured that out by the fact that your surgeon is from time to time, or your oncologist or whatever, is getting a scan. If they knew it was never going to come back, you would never really need a scan again. So the fact that they are scanning is because we know these can come back. And the likelihood that they're going to come back depends a little on whether they were able to take it all out or not. If they were able to take it all out, the chances that it will come back are less, but not zero, because there may be some cells hiding. If they can't take it all out, then as I showed you, the chances of it coming back are about 65%, 35% that it won't, a little bit lower in patients with neurofibromatosis, but for everybody there is a chance that it will come back. And that's just the reality. The issue, just to make it clear, is that once you hit 20, it is exceptionally rare, super, super rare, for one of these tumors to ever continue to grow. So no doctor can ever say never when you ask them if something can happen, right? We all have this conversation with our kids where they keep asking a question until it gets to the point of ridiculousness. In this circumstance, if you can get your child to adulthood, that will take care of it, as long as we didn't need to use the therapy that becomes the greater risk of both progression or transformation of the tumor to something more deadly. And that's why considering the upfront therapy becomes so important.
Thanks, Mark. So there was also, as you might expect, questions regarding radiation, because certainly a lot of the folks on the call might have had their child radiated as part of the treatment. So the questions that I want to provide you, one is specific in that our child had proton radiation at age 10. She's doing great. Will we expect future cognitive deficits, or would we have noticed them at this point?
Yeah, so one of the difficulties for oncologists in terms of determining exactly how to counsel parents is that obviously, as I said, the location of the tumor, the age of the child when they get their therapy will impact exactly how much cognitive damage is done. The other thing is that unless you have an absolute identical twin that is following through in every aspect of their life identical except for the therapy, how do you know what cognitive issues your child will have? If you just think about yourselves and your own families, some of us are incredibly gifted at knowing multiple languages without a lot of effort, and other people can't seem to learn a second language to save their lives. That some people are just naturally musically gifted, and others, it doesn't matter how many music lessons they take, will never learn to play an instrument or be good at math or those kinds of things. And we're not talking about people that got therapy for a brain tumor. We're just talking about the natural human variation that occurs in all of us. So when a child that got treated for a brain tumor is having difficulty in math class, is that because they were never going to be good at math, or is that because the treatment actually did something to it? And so it's very hard for us to say with any specific certainty that this particular problem is caused by this particular treatment. But what we have done is done these studies where if you take patients that received radiation therapy for one of a variety of reasons, we know that overall that lowers the cognitive ability. And again, the younger you are when you get radiated, the location where you get radiated, and the volume of the radiation will determine the degree to which you have those deficits. And obviously, if you've had radiation, if you've had deficits, I must say, remember, if we can identify which deficits you've got from your therapy in terms of your cognition, we can often develop therapies that will help kids get around them. In the same way that if your radiation damages your optic nerve so you have visual problems and glasses would help you, why would you not give your child glasses? Well, if doing neuropsychologic testing can show that your child is having problem solving in a particular direction, providing them the techniques to solve questions in a different way will often allow them to arrive at the correct answer. So many families don't want their kids tested because they're worried someone will find a problem, whereas by having them tested often allows us to solve those problems.
So Mark, you're really recommending follow-up testing on a regular basis in order to track that?
Yes, every child should have, not just in addition to a scan and exams, but they need detailed neuropsychologic testing, not just because you got radiation or didn't. Remember that you had a tumor in there that was pressing on your brain, and then you had a surgeon go in and cut something out, and that can already have had an effect on the brain. So you do your children a service by making sure that if anything has occurred, that we detect it early. Whether it was going to be there even without the tumor, we can't always be sure, but optimizing every child's performance in the same way that our kids that are not good at mathematics, we get them a tutor, even if they haven't had a brain tumor. Why would you not do the same thing for a child that's had a brain tumor and an extra insult?
So Mark, I'm going to try to squeeze in two questions because I want to get some answered. There were so many that were provided to us. Maybe just a brief view, if it's possible, in terms of the question of retreating with previous chemotherapy. The question is, can you retreat if you've already used a type of chemotherapy?
So that question can be answered in two ways. Yes, you can keep using chemotherapy over and over and over again. And one of the things that's interesting is, remember how I showed you that chemotherapy will often effectively stop completely about 35%. 65% will eventually recur. need more therapy. When you treat them the second time with a different chemotherapy, again, about a third of those will never need to be treated again. Another 2/3 will, and you keep kind of paring them down that way. The other thing that's absolutely unique to pediatric low-grade gliomas is that normally once you've used, if you have, for example, an infection and you use an antibiotic and then the bacteria becomes resistant to that antibiotic, that's the only treatment you never use again. They've become resistant. One of the interesting things about these tumors that again has to do with the biology, and this will be a topic for the next webinar, is not only can you retreat them with chemotherapy, if it's been a little bit of period between, you can even treat them with the same chemotherapy, the identical chemotherapy they already got, and you can still make the majority of them respond, something that's unique to pediatric low-grade gliomas. So sometimes your oncologist will actually tell you, let's just do what we've already done. It may well work again, and they would be right.
Excellent. Okay, Mark, thank you very much. So again, to your point, we're going to take a lot of the questions that we received, and that will also become a basis for the next webinar, which we're shooting for September. So last question for you. At the front, I talked about the foundation and that we had been successful in galvanizing some parents and raising $12 million, but we realized that's kind of not a lot of money in the world of research. What do you think parents should be doing to help make sure the research continues?
Well, I mean, I think parents have to understand that although this tumor is the most important thing in your lives once your child gets diagnosed with it, in the global scheme of, if you just think of what I told you about the survivability of this, imagine when you go, for example, to the National Institutes of Health or the National Cancer Center, the National Cancer Societies, those kinds of things, is to some extent you are the luckiest unlucky people in the world because your kids are going to survive this, whereas there are a lot of highly malignant tumors in adults, breast cancer, colon cancer, prostate cancer, lung cancer, that are way more common and kill a lot more people. And so as they're making decisions in these foundations and funding agencies for where to put their resources, of course, you don't seem to rise as high to that list because it's very clear that you guys are relatively well off. Now, of course, we don't see it that way, and I suspect you don't see it that way, but if you understand it from that point of view, virtually all of the research, and when I mean virtually all of the research that has happened in these tumors has not come from the federal authorities or the major cancer foundations. It has come from the parent organizations, including Kids Brain Tumor Cure, which was really what started the brain tumor program here at the Dana Farber and Boston Children's Hospital, a program that now has some 50 physicians and scientists focused solely on trying to understand how to treat these tumors. That happened because parents made it happen, and you can't wait for the government to step in here, particularly with all of the budget cuts going on. The reality, obviously, is if you want this done, you're going to be the ones to do it.
Excellent. Thanks very much, Mark. So we're going to wrap up now. First, I want to, on behalf of our foundation and all the listeners, Mark, I want to thank you for sharing your insights. Our goal was to provide our parents with information that could help them get the best care for their child, and you certainly delivered today. So a deep appreciation to you. With regards to next steps, first, thank you for attending and being such participative folks in submitting questions. At this point, the webinar is going to close, but it will be available in a matter of days, and you can check kidsbraintumorcure.org for more information related to that. We also, as Dr. Kieran noted, we will have a September webinar more focused on the topics he described around drug development and clinical trials, et cetera. In the meantime, please reach out to us if we can help in any way. And please feel free to learn how you can get involved. You really can make a difference as a parent in galvanizing people, in advocating for your child and for getting more research, and helping us really with the cause. So we would welcome that. So for today, we thank you again for participating with us. We wish you all the best and have a great day. Thanks very much.